All right, here we are. New time. Hope this audio is okay. We're going to run it from here. You let me know if you can hear it okay once you guys get in. We're going to have this coming from up here. Actually, best way might be coming down. Coming down. Here we go. Let's come in from over here. Bang some stuff around. Welcome to the late night show. Let's see if we've got sound. Okay, hold on one second. Okay, my microphone. Can you guys tell me if you can hear me all right? And we're going to get rolling. Great. So we're rocking and rolling. We're in a new location. So anybody who's been kind of following along over time knows that I am real good at dropping the stream. So we're going to try something new today. We're going to try not dropping the stream. And the way we're going to do that is by doing it from the gym. So we are in a new location, new time. We're really just crushing it. And yeah, and we're gonna get after it today. So that's the plan. So last week, if you guys were here with us, we we had the 7 ways neck joints affect your brain, the role of cervical joint error. And we got through 5 of them, and then Restream blew up and off and going. And oh man, look at this team. Alicia Schmidt, good to see you. KG 2022, thanks for joining us. Tamara says loud and clear. Michelle Schellenberg says, sounds good, hello. Kelsey Leonard's on, she says yes. And then Ashley DeLeo says, I can hear you. And then my kids say, hey, Dad, we can hear you. You should be in bed also. So there we go. All right. So let's have some fun today. I got a little bit different setup, so you'll just have to hang with me. But I'm going to get after it. So we're going to kind of pick up where we left off. And we are going to see if I can pull everything up. And we'll just, actually, excuse me, not where we left off. We're going to kind of recap a little bit. We'll kind of burn through what we talked about last time. And then we are going to keep progressing. We'll take some questions. We'll talk about things as we're going. But this is where we are. The 7 ways neck joints affect your brain and its function. So this is kind of based on this paper, which is, it's a great paper. It's one that has kind of like, we're kind of recapitulating some good things. They're adding to it. They're making some changes. Really, really useful. It's really useful in the body of work where we talk about cervical joints, the way the proprioception integrates within a greater system, and gives us a basic knowledge about where our head is in space. Turns out where our head is in space is very important for being able to manage most things. So if you don't know where your head's at, your brain just is really churning at that point, and energy demands go up. Autonomic and reflexogenic systems become impaired, and we have a hard time functioning, which leads to symptoms that we often end up talking about. So that's where we are. Corey, good to see you. Amanda, glad you're here. Eileen is back, so we are ready to go. Let's have some fun. So we talked about why your neck matters. It's not just about movement, it's how your brain processes information. When anything has gone awry, leads to symptoms. We're talking about the 7 ways. Number 1, your neck joints can confuse your sense of balance. Now, normally they're a force for good. They help add to our sense of balance. But if we have an error in them, let's say, boom, whiplash, we got in a car accident, you're snowboarding down a hill, fall back, whip your head. Anybody that's been snowboarding, you probably have done that before. You fall on the basketball court and go back and yank your head, or you fall ice skating, fall off a horse. A lot of things with falling, it turns out, fall out of a tree. Any of these things can cause these little sprains or strains in the neck joints. And when that happens, we can get some weird inputs from those joints, from those receptors about where head position is. If they're not good, we feel it. And that mismatch, you can just kind of write it on your mind, like the size of the mismatch between the sensors in your neck, ears, and eyes will dictate the size of the symptoms you experience as you move through your life. So that's like a rule, a heuristic that you can put to that. Okay, so let's talk about number two. Number two, that same constellation of things that can affect your balance, changes in your neck can also affect your vision. So changes in neck are tied to positioning of your eyes, which means that it can change the position of your eyes, station of your eyes, which can affect binocular vision, causing blurred, difficulty focusing, difficulty changing depth, difficulty interpreting light. Okay. Number three, you experience headaches as we have changes in the position or posture in our neck. Then we can see that irritation of the muscles or of the joints in your neck can cause different types of referrals of head pain. So if it's musculogenic, we tend to see them come up around the eyes. Sclerotogenous can come up around your head in this way. That's like if it's in the joints. But then we can also generate different positions where we can even start to pinch on stuff that travels through your neck. Could be your spinal cord on the inside, could be arterial blood vessels going up, venous blood vessels going down. And then we have some nerves. We have the sympathetic chain and we have the vagus nerve that also travel through here. So you can see all of this magic is going through your neck. So changing the mechanoreception can change the feedback. And if we change the feedback, we get an outcome where we may have symptoms, headache being one of them. Cool? Okay. Then we talked about number four. This one hits home for a load of people. And it's one that is very poorly paid attention to when we think about like maybe healthcare writ large. We're not usually thinking about it this way, but I would invite you to consider it, especially for people that are dealing with POTS and dysautonomias of varying kinds, orthostatic intolerance, orthostatic hypotension being two important ones. Also, supraventricular tachycardias can be included in this group, and arrhythmias writ large, so PACs, PVCs, etc. And you can see that. So the simple language of this is faulty joint input can overstimulate, so we can have too much noise going in, or can be inaccurate, causing those normal reflexes that we have in the brainstem to get misinterpreted and then cause changes in autonomic reflexes down the line, things that affect your heart, like heart palpitations, things that affect your digestion. So this may be slowing of digestion, malabsorption in digestion, could also trigger vomiting episodes or things like waxing and waning constipation and diarrhea, which ultimately over time can lead to things that many of you have heard of, things like SIBO, small intestinal bacterial overgrowth, where when you have these problems that exist over a larger period of time, then we start to see changes in the actual GI tissue, or what's commonly referred to as the microflora or the microbiota or the terrain in the gut. So the terrain is where the microbiome lives. And if you change the pH in the system, the microbiome changes and we can get the dysbiosis, or kind of like bad bacterial overgrowth, as it's commonly called. And then the third thing on there is temperature dysregulation, where we can have difficulty with modulating temperature regulation in the central system, like your core temperature, but then also peripheral management, where it's harder to control sending blood to the extremities, keeping blood in the skin without causing problems with blood flow into the brain. So these are kind of the big ones. Cool. So now we're at number four. And then we ended somewhere around here with brain fog. And this is that kind of lack of high caliber thinking that is super common, not just with problems in the neck, but problems with basically anything that affects information processing within the brain has a probability of causing brain fog. So common ways we think about brain fog is being just mental fatigue. I can't think very well. I get tired really fast. I can't think through a problem all the way. I can't envision things in my head. Secondarily, people will have short-term memory problems where it's just like hard to like remember the easy stuff from earlier in the day. Long-term memory problems where it's just hard to recall. And that's pretty common actually, where it's like, what is the word? What's the thing I'm thinking of? And it's just not popping up. And then the one where we can really kind of expose where those things are coming out is when we have people multitask or dual task. And when they're doing multiple things at one time, we can see both tasks fall apart. So the ability to be able to generate that signal, filter it through, and execute it at the same time takes a dump on you, and you see where both of the systems are compromised at that time. So that's kind of where we ended up. So we're kind of caught up. Spent a lot more time on it than that, but if you want to go back and watch the previous replay, it goes up till about this point. I'm reading this note from Corey. He said, thought the stream drop last week might have been his fault with the provocative COVID question right before it. Had to attend today to catch up the rest of the chat. Yeah, we did talk a little bit about COVID. We didn't know if we might have got dumped because we got just fully booted off YouTube. I didn't get any strikes that I know of, so we'll see. But nothing that was bad. We're just kind of trying to make some sense of the way people feel and what they've been going through. I think it's a worthwhile conversation, but you're right. It is a thing that is hard to talk about in just a truly objective manner. A lot of charged emotions that come with it, rightfully so. So let's keep rolling. Let's do number 6. And then if you guys want, I see there's a few of you on the stream. Let me know if you have any other questions. I've got 2 questions that are kind of loaded up from earlier, and we'll do those shortly. And then if you guys want to load anything in here about what we're talking about, let me know. And then also, if you don't mind, we're at a different time today. We're 2 hours later. It's more convenient for me because now my kids are heading to bed. I got to spend a little bit of time with them, which was super cool. But I'm also interested to know kind of what suits people in terms of being able to get on, ask some questions, have a little fun. So just let us know. Irene, thanks for being here. She says hi to everyone. Those of you on YouTube can see. And let's do number 6. So number 6, we also have postural imbalances and coordination problems. So it makes sense that if we mess up some of that mechanoreception, remember mechanoreception is just the ability to detect motion, detect movement changes. Okay, if we can do that and we can affect those, then there's a good probability that our posture is going to change as a consequence. It's going to adapt to whatever our mechanoreceptors are telling us. And if our posture changes, then that changes like the static position of our body. And that may also mean that we have a harder time with ambulation, walking. But even more so is we can generate problems with coordination issues because we're not getting peripheral signals as clean. So the peripheral signals coming up and the peripheral signals coming down may be affected by that a maladapted sort of a system as well. So big things to take home. When it miscommunicates, the alignment in your body fails and suffers. So those of you that are here as chiropractors or have experience with chiropractors and PT as well to a degree, this is where you see the evidence of changes in the postural system. You might have somebody that, has you stand up, looks at an x-ray or takes a picture of you, takes a picture from the side, watches you move, and you realize like your posture is weird. Maybe your head's tilted way forward, or your shoulders are rolled, your head's cocked to the side, or your body's twisted, right? All of these things are downstream effects of having this miscommunication over time where it becomes a more consistent postural adaptation, which can then, over longer stretches of time, lead to things like bone spurs. So things that we would think of as, like spinal bone spurs, but we don't really call them that. We call them osteophytes, but things where we start to get ossification of the discs, the mobility in the spine starts to change and become painful. We see changes in the ligamentous structures thickening and becoming more stable as a way to try to hold this new posture. this tends to be a more painful period of time as well for people. So definitely something that we want to address long before it ever becomes a problem. The chiropractor in me is just like had this beaten into my soul, so you can understand what that means. Um, and things you might notice about yourself, you may notice that you kind of stand unevenly. You might feel like your gait is off, like you're stumbling or you're being pulled to a side. You might also notice that it's harder for you to do things like just lift your head up or move your arms overhead without getting dizzy or thrown off. You might notice that your hands are less coordinated. You may feel heavy at times in your arms, heavy in your legs. And you may notice that you're more likely to drop things, kind of in that pattern of movement where we see that neck becomes the conduit for a lot of the things we experience in this postural system. Cool. Okay. Real quick, just reading a couple of these. Eileen says, hairdressing for 37 years. Good for you. Love that. Commitment to your craft. Poor posture for a long time, rounded shoulders, which then progressed to dizziness, and symptoms slowly show up for years. And this is the common paradigm, and we have to try to do things where keeping that motion in your spine is super helpful. I love this fellow. You could check him out if you're interested. His name is Ido Portal. I'm not sure how you say it, but he is a person who is just obsessed with movement, locomotion, strength, mobility, coordination, just all these different ways that the human body can move. And one of the things that he always talks about is this Chinese proverb that says, "You are as old as your spine," meaning the more mobile and youthful and spongy and soft your spine is, the more mobility you have, the better nerve flow occurs, the better the whole system works because the electrical system can be coupled. And I heard him say that years and years ago, and I still think about it on a weekly basis. So keep your spine young. That's a thing that anybody can do on their own at home, trying to keep moving, keep living. Thank you, Eileen, for sharing that for us. Tamara is saying she's working with a neurophysical therapist. I don't know specifically what that is, but given some hope, which I really like, trying to avoid neck surgery. Didn't have the chiropractic experience that she'd like, but that's okay. Nomad Over Normal says, excited to catch the live. Oh, cool. Girlfriend's booked with you for later this month. We're excited to drive from New Jersey. Excited, nervous, ready to get back. I think those are all the right feelings. Just to take an aside from our comment here, but I think a lot of people that have been over to see us, and then also people that are anticipating it, that's definitely probably the right feelings. It can make you nervous when you're coming in. Just the travel, the hope, the excitement, and then also just like seeing what's over the next mountain, seeing if there's a way to get back. So I'm excited to see her. I hope we can be useful for her. But I do know the one thing we always really promise and really try to deliver on is we want to make sure that we're excellent at data collection. So can we collect data that helps us learn? And from that experience, if it can help us learn, then we can have some new strategies available, right? So we can say, oh, well, maybe we should look at this as a problem. And if so, then we can open up this toolbox that wasn't available to us before and hopefully try to find something in there that fits. So I'm excited to see you guys. Thanks for being here. And it'll be really great. We got Kelsey. Kelsey left us a little note here. Said, I'm going to move my camera because actually I'm going to move this. So I got a different setup. I don't have my big old giant monitor, so I got to move some things around. Let me see if I can just move the whole thing. That's better. Okay. So I have POTS and tried lunges with a barbell yesterday for the first time in years. Okay. My heart rate jumped to 160 and I had a lot of palpitations, so I stopped and squatted down. Heart rate dropped to 50. Is that normal for POTS? All right, so this is actually a test that we do. We're kind of jumping off topic, but I think it'll be useful for people because it's a good learning experience. And this can be a thing. So I'm gonna pull out a couple things to consider. Number one, Heart rate jump to 160. If you're loaded underweight and you're doing that big Valsalva, it can be more reasonable to see that heart rate really climb up. And the reason for that, let me see if I can draw this for you real quick. I'm gonna change my, I'm gonna jump out. Let me back up. Actually, let me close your eyes. Don't ruin that. Okay. No, 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 no. But actually, we should have brought that slide in a little sooner. All right. So if we think about this, when you're doing a Valsalva, you've got your heart. I'm going to draw a heart in a fun way. Okay. But you can just think about it. Okay, no, that's a terrible way to draw it, actually, for what we're going to do. Let's draw it like this. Okay, so we've got 4 chambers here. I don't like that either. Let's just draw it in a lame way. Okay, so we got 4 chambers. When you just think about this left ventricle, you just think about that as having a tube that goes out to the body. And then you've got the right atrium's got a tube that's coming in from the body. So if I give a lot of pressure, what am I doing? I'm using my diaphragm and I'm loading my thorax. I'm creating pressure in the intrathoracic cavity. So I'm making more pressure. But when I do that, if I look at this tube here, I'm going to be exerting pressure in toward these walls. So I'm going to be kind of closing the walls of that by the pressure in my chest. So when I do that, in order for my heart to keep ejecting blood well, I've got to increase the contractility of my heart, and I'm likely going to make it beat a little quicker. And most of you have experienced that anytime you're like, lifting something heavy, like really straining to like have a bowel movement or something like that, you'll feel like that increased pace where your body's trying to catch up for that change in pressure that can cause the intrathoracic pressure against these arteries and against your heart. So your heart's got to work a little harder. So if we're doing something like a squat or a lunge that's pretty highly loaded, that intrathoracic pressure can cause that big spike in rate. What's curious, what we look at is actually what it does to the pressure wave itself. Like, when I do that, does my blood pressure drop, keep going, and it doesn't recover and come back up like a nice roller coaster would? And then the question is if we're doing that and then we stop and squat really quickly, sometimes it depends on how much blood is pooling in the lower extremity. But if I squat, like if I've been working my legs, chances are I'm going to get more blood flow to those legs. And if I squat quickly, I'm going to push a lot more blood quickly to my heart. When it does that, depending on the sensitivity of the system, it may cause a quick drop in the heart. We also may see that if we see changes in sympathetic outputs where the sympathetic latency is high, it doesn't kick in fast enough, and we can see that big drop in the heart rate. And there's actually a test that we used to do more commonly where this was part of the test. You'd listen to your heart and then you do that and then drop it down and then see if we were seeing changes in that cardiac output. So it's actually part of a test that we do. Is it normal? That's always a tough question. If that is a recovery position that is suitable for you, then those 2 things may be in range. By being under load, you may see that 160 isn't that crazy if you are under a high enough load. And dropping down to 50, although doing it quickly, maybe that we don't like to see it drop too crazy fast because it just means that either there's so much blood being pushed into the system that it normalizes it, and that's probably not perfect. Or we're seeing these like latency responses or the reaction times are low, so we get these big peaks and valleys. But if you're working out and experiencing this, though, I mean, it's not completely dead out of range that those things could happen, but that's what I would want to look at is if we're having normal sympathetic responses to the Valsalva maneuver. So that's the way I would think about it. Let me know if you want me to clear that up anymore or ask any further question, but that's a really good question. It's a Valsalva test that you are doing on your own. Okay. Let me see. It looks like I'm catching up on. Okay, so Eileen, we're talking about hairdressing, and then we kind of jump into this convo back into this one. Now we're doing upper cervical chiropractic care. Um, Upper cervical changes are happening now, but it looks like slow. That's fine. Slow and steady wins the race. Change is the big thing. So we talk about this a lot with patients. The fact, the first thing that we're trying to prove in any case is, can it change at all? Because if you can't move the needle at all, then that's a little more troublesome, right? So if you throw everything that you can at something, it means that like that's probably not responsive for this. But what it can inform you of is if you need to change what you're doing. But if you can make a change, if you can move the needle and you can do that reproducibly, even if it's small, those small wins can really add up. And sometimes they feel small, but actually, if we do a look back, there's been a bigger change than we realize. It's just hard when you're living with it every day and you don't see those big changes. Like if you're losing a pound a week, you may not really notice that, but after 6 months, you may see someone that you haven't seen in a while and they would be like, whoa, that's a huge change. So just things to keep in mind, just a little bit of a pep talk. But if you're seeing changes, they're there. I think that's great news. I would not scoff at that. Follow up to that, lots of dry needling, movement changes, got to stay patient. It's hard, doesn't happen overnight without consistency. Especially, I mean, you're talking about 37 years of hairdressing. I'm sure you're working your tail off. It's a long time positionally. Changing structure usually takes longer because that stuff's not meant to change quick. It's meant to be stable. That's the point. So when you're trying to change something that's stable, it's going to take a little bit of time. But I love your attitude. I love that you're keeping up with it. So it's awesome. Awesome, awesome, awesome. Let's see. Tamara, what's your opinion on neck adjustments? Maybe I just need to find the right chiropractor. Like having an adjustment is a tool. So just like anything else. So if you're doing something where you're manipulating the neck, adjusting the neck, the the thought behind that would be to be able to input into those joint mechanoreceptors that we've been talking about. Let me get us back on track here. Hold on one second. Let me find the right slide. Okay. So if we're talking about those mechanoreceptors, and as a chiropractor, if we boil it down really simply, when somebody has a manipulation, you're giving a different input into those sensors. You're giving a mechanoreceptive change. What that does is by stimulating the mechanoreceptors, you're stimulating that whole pathway within the brain. And if it has been immobile for a period of time, like that particular segment isn't moving correctly, it'd be kind of like, some of you have heard me do this analogy before, but like if I tape my fingers together for a month and I just walked around and did everything like with these fingers taped together, there's an interesting thing that happens, and they did this study with monkeys. What they noticed was before you tape their fingers together, when you touch a finger, it lights up a specific spot in the brain. And then if you touch a different finger, it lights up a different spot in the brain. But after time of taping their fingers together, even when you untape them, when you touch those fingers, it lights up the same spot. So basically, those fuse together and becomes one spot. So if you think about that and then you apply it to what's happening in your neck, if you've got motions, remember this thing moves in 3D, just bends around like a snake. So if there's ranges where you're limited, and you can kind of sit in your chair, and most of you will know this, right? So if I do different motions and I find like, oh man, like I'm really stuck like this, or I'm really stuck when I do this thing, or it's painful. You may feel that number one, it's hard to get the whole range to go there, but that doesn't even account for just the individual segments where you might have one that does a lot of movement and another to make up for another one that doesn't move at all. So if we apply that kind of like hand taping philosophy or concept to that, if I've got neck joints that aren't moving correctly, then I want to try to introduce mechanoreception so that I'm not binding all of those, like neck receptors into one spot in my brain and using it like a big clump. I want to be able to use them individually and create that motion. And sometimes that signal um, is easier to elicit than others. Some people using a manual adjustment can overwhelm the mechanoreceptors, like we talked about. There can be too much noise, and it can make you feel dizzy. It can make you feel nauseous or sick. Um, and in those cases, you might consider that there might be too much signal going through there. We have to go slower in being able to do that. And in some cases, it might not be enough signal, and we're doing things and it doesn't feel like it generates a result, or it may just make you feel weird because it's not enough to really augment the signal. So just like you would stimulate anything else, a chiropractic adjustment or any sort of manipulation can be looked at as like, are we applying the right dose to that mechanoreceptor to get the change that we're wanting to get? Or are we applying a generic dose and then like wishing for the best? Obviously, you can tell which one I think is more useful. Cool. Okay. Where's my pointer? There it is. All right. Yeah. Thanks, Tamara, for saying that you appreciate that. It really means a lot to me and everybody on. Kelsey also says thank you. From Michigan, hoping to schedule a visit. That would be wonderful. I am hoping that I get the opportunity to see you. But either way, I'm happy to have you here, and hopefully, at least it gets us somewhere toward improvement just from being here. Cool. Okay, I'm gonna KG 2022. I'm gonna get you next right here. Courtney, I see you. QQ and Marcy, I see you as well. I'm gonna get to you guys in just a moment, but I'm gonna get this in order. So KG 2022 says, what do you think about taking Guanfacine for, I've been taking it for IST, dysautonomia POTS, seems to be helping a lot, but still having issues with walking, can't walk much without problems. It's interesting that you'd say, number one, I'm not a medical doctor, so again, not medical advice. Guanfacine IR is interesting because that would be an atypical use for. A lot of times they use it for, well, maybe not atypical. Commonly, you'll see these used in conjunction with things like ADHD medications. So if you think about Ritalin, Vyvanse, because of the sleeping issues that come with that, Guanfacine is often used as a way to help mitigate that and help people get some sleep. I'm curious to know, it says it seems to be helping with the IST. I'm interested about the fact that we're talking about IST and POTS as a correlate. So what that means for everybody is that the heart rate resting or even laying down is probably somewhere over 100, and that we're still getting a pretty significant uptick when you're standing up in the heart rate. So what becomes more interesting to me is kind of what's going on underneath that. Are the normal cardiovagal reflexes available? That's the first thing we look at with ISTs, just to see if we're able to generate the normal inhibitory barrage to the SA node, versus looking at it as a primarily cardiac problem. And then you travel up from there and see, are we having normal outputs from the nucleus ambiguous? Is the sensory aspect of the NTS appropriate? And away you go. And then curiously, with the POTS component, we want to know if that is just from the lack of preload that's coming in because it's beating so fast, or is this from something where we're seeing changes in vascular delivery? So that's where you'd probably start. Guanfacine is going to be just a way to kind of juice that system so you can let the heart chill out a little bit and try to fill more. That's usually the way medically we've seen these. My experience, the way that we've seen people try to manage these with medicine is to say, okay, heart's beating too fast, which means it's not going to fill effectively because you got to get that right atrium filling blood from your body to be able to pump it back out. But if you're pumping so fast that you can't fill your heart, the cardiac output, the amount of blood that you can eject from your heart goes down. So if that happens, then we see, even though the heart's beating faster, the amount of blood it's pumping goes down. So by trying to slow your heart down, you're just allowing it to refill a little bit faster. So it kind of assumes that you're on a runaway train with your heart, and there's nothing that you can do to slow it down. Another perspective on that might be to look at it and say, why does your body, why is that the mechanism for how it's trying to solve this problem? Why is it doing it with tachycardia? Or is it that it just can't use the normal mechanisms to slow it down? And I think those are exciting and interesting questions for people in this scenario. Cool. Courtney, I'm glad you're here. Glad to see you. And you have a good question. Is there imaging that can 100% show that a person has cervical joint error or CCI that's causing symptoms? Asking for a friend in the mirror. So, yeah, so there's a couple pieces of this question that I think are important. Number one, cervical joint error can largely comes with motion, right? So it's hard to see if there's an error when it's static because you can't tell if it's moving weird, right? So if you look at my hand and I go like this and open it, you would say that doesn't look super weird, right? But if you ask me to do the same thing, but instead I kind of do like one of these, you'd be like, that was a little bit weird, but you wouldn't be able to know from this position or this position how I got there, right? So if there was a lot of weird stuff that happened on the way there, but I could get there, you wouldn't be able to catch any of that. So things that are in motion tend to be more useful, but you can also do kind of imaging like flexion extension CT, flexion extension X-ray to look at kind of the snapshot of those positions to see if there's something up with the positions. Now, the position doesn't necessarily beget mechanical changes as far as the neurology goes. So I could have ligamentous changes in the neck, but that don't necessarily correlate with symptomatic expression from joint error because their mechanoreceptors may be intact. It just may be capable of moving farther. So if I take it to the far end ranges, I may find that it moves further. But in practice, in life, I don't actually find myself in those scenarios in that kind of unprotected way. So when we think about craniocervical instability, we're looking purely at do the ligamentous structures move beyond what we would consider a typical range of motion? And then the second part of that would be to see if those are the things that are indeed causing the symptoms, or if it's something that is being interrupted by that laxity occurring at a high level. So you could use things like a dynamic motion X-ray, DMX. Those will look at different motion segments. But again, those will show if there's instability, but you don't know for sure if that instability translates into neurological changes, if that makes sense. So 100% for the joint error, you can't know for sure because you're thinking about like the mechanoreceptor signaling. Can you know if the CCI is there, if the craniocervical instability is there? Yes, because you can look to see is that joint capable of moving too far. It'd be the same as if you had imaging, you had like an MRI on your ankle after you sprained your ankle and you're like, yeah, that ligament is torn, right? And you could see that. But a lot of people have torn ligaments in their ankle, but are able to do balance exercises and training to where they don't repair the ligament. They use the muscular control as the main model for how they create stability and pain reduction. So that's a long answer. There's nothing that's 100%, but what you can do is understand if there is ligamentous changes. And then you do the next part, which is kind of understanding if those ligamentous changes are turning into neurological compromise. And we can always talk about that more, as you know. So give me a shout, let me know. Hope you're doing great. Hi to everybody back home, and hope you're having a good night. Okay, QQ. Neck movement makes my tinnitus worse. And that can happen, especially if we have changes in mechanoreception in the neck, in your jaw, but can also be when you move your neck, if we're getting any jugular compression and it starts to back up into your ear, that a lot of times will cause tinnitus. Pro tip, if you notice that it's pulsatile, you feel your heartbeat in your tinnitus or tinnitus, then you move your head and it goes away. That would be a good reason to go ahead and get checked out and see if that internal jugular vein is causing you some troubles. Cool. Yeah. Yeah, this one is tough. So Marcy says the same question, getting an uptight. That's kind of a fun, it's kind of a fun error because it's true. Getting an upright MRI with flexion is proving to be a challenge. It's really hard because it's hard to get a magnet big enough to really uh, to do that in that flexion extension position. They're usually backed up, hard to get into. You can get a CT that way as well. Um, those are a little bit more common. Um, but yeah, even if you can get the DMXs are a little bit more available. So the digital motion X-ray, which is like a fluoroscopy where they do it while you're moving, and sometimes those can be useful if they're more accessible. So something to consider. Cool. Tamara, thanks for saying thanks. Courtney, thank you. Makes sense. Let me know when you want to play some hockey. KG22, thanks for your input. I enjoy watching your videos as well. You guys are really nice. Thank you for that. So cool. I hope I hope it's really helpful. Marcy says Freudian uptight. That's what I was thinking too. Oh, cool. Thanks for the good questions, guys. I really do appreciate those because those are ones that a lot of people ask about. So I appreciate you doing it here where it's kind of memorialized and people can hear it. And then we can, if my answers aren't good enough, also in terms of like I'm not clear, it's a difference if I can't answer it or if I say I don't know. But if my answer just isn't clear, then feel free to ask a follow-up. I'm totally cool with that. Okay. Okay. Let's go. Let's do number 7, shall we? So we talked about postural imbalances, we talked about coordination. And then the last one is increased sensitivity to motion and increased sensitivity to sound. Oh, I keep getting distracted. Courtney's throwing them at me. She's in her pickleball range. You know what? Don't start because you know I love some pickleball. And it's getting to be the season here in Michigan where you're not freezing playing pickleball anymore. So look out, world. We're about to get wild. Who anybody wants to play a little 4-on-4, just or 4-on-4, 2-on-2, you just let me know. We'll get after it. Courtney's a shark though, so be careful playing with her. All right. So number 7, increase sensitivity to motion or sound. These ones are ones that are a little bit harder to consider, but if you're increasing the overall signal, we talked about that vestibular nuclei last week. If I'm amplifying the signal from my neck and I'm screwing up like the motion signals from my ears, I'm also overriding those motion signals from my eyes. So what can happen is even though it's just a neck thing, there can be times where people are riding in the car and makes them feel overwhelmed or dizzy or nauseous. There can be times where you're like in a coffee shop or in the grocery store. A lot of you guys have experienced this. Just walking up and down the aisles can be overwhelming. And you'll see that. And then we'll do the more simplistic eye tests. We'll do not like oculomotor tests. We'll do kind of in-depth vestibular testing. You're like, it's actually pretty great. And then you augment spinal activities and all of a sudden it's like, oh, that's way better. I can see again. One of the common ones we'll do, I think I talked about this before, but I'll do it again, is we will set up like a Snellen chart and we'll have people kind of move their head and they'll notice that the Snellen chart becomes less clear. And then we can do things like distracting their head or, compressing into their traps and activating some muscles or doing some different, kind of checking to see where those segments don't feel correct here. And then we'll look at the vision and we can actually see it change. Same thing with that red saturation, where we'll have them just do little bits of movement and changes in just little sensations in your neck or in your arm or in your shoulder clears up your vision. So it's really, really useful because and I'm not being critical of anybody here, but sometimes it's really easy to kind of get in a groove as a healthcare provider and you just kind of do the things and you just crank out and you're like, I'm going to do this because it gives them a little bit of help, which I think is cool. Like throwing some glasses on, helping acuity. That's great. It really helps people get through the day better. But also that acuity change, if it's from something like this, may persist, gets worse. You don't, different symptoms show up, and then then you don't know where they come from because you got lost in the fact that like, well, I can see now, but something's still off. And so we end up kind of like putting a little bit of dirt over some of the problems, but it kind of just leads us away from the things that tend to be like at the core of it. So we're always preaching about like figuring out what's behind it, what the root cause is. And that feels, like it gets overstated at times. But the reason it is important is because you can look at healthcare in two ways. Well, you can look at it in more than two, but I'm going to give you two easy ones. You can say, I feel bad. I don't like the way I feel. So what I'm going to do is I'm going to do something that just makes me not feel so bad, which I get and I've done and I understand. So I'm not criticizing it at all. But sometimes if we do the thing where I'm just going to like try not to feel the thing that bothers me, it can cause the original thing that is the failure to just keep persisting. And sometimes that means it gets worse, or it means you get symptoms at times where you don't expect and you don't know how to correlate them, and then they get frustrating, and then time goes by, and then it's harder to fix, and away you go. So I'm not opposed to doing things to make yourself just feel better so you can live life. It's short, I get it. Also, it's useful, my opinion, to think about it and say, I'm going to take advantage of the fact that there is a product here that helps me not suffer as much. And then also at the same time, I'm going to work toward solving the underlying problem so that I no longer have to use this crutch. And I think those two things married together. I mean, I trend way over here toward like solve the underlying, even and like suffer through it, but you shouldn't necessarily subscribe to that just because I do. Um, but I do think there is a path where you can run those things in parallel. And then once you're feeling a little more stable, you can always drop off the things that help you adapt. And that may be a useful way to think about it for some people. Okay. Um, Additionally, things we talked about tinnitus, changes in your neck can change sound. So I've had number of patients that can change the pitch of the ringing in their ears by moving their neck. They can change the pitch by moving their jaw. They'll change. They can change it by making pressure in their head. So all of these things are influencing the integration at a central level. We've seen cool cases where, like we talked about with tomorrow, with using chiropractic manipulations, where you can manipulate that joint and it actually takes that tinnitus right down. Or you can do things where you strip out the scalene and that ear opens up and then tinnitus goes away. So it's very, very interesting ways that neck can influence it. So it's kind of, if you haven't walked down that road, for some people, if it's really dramatic for you and it's irritating your life, then that may be a road worth walking, especially because the downsides are really low as far as being able to solve for it. So for what it's worth. Cool. All right. Oh, hello, Megan Bradford. Welcome, welcome. Still daylight hours. Marcy says, thanks. Like that approach seems logical. Yeah. So thanks so much. I appreciate you guys being a lot of manners in this group today. I really like that. I appreciate that. It's awesome. Okay. Let me see. Am I missing anything? So I'm just going to circle back and just talk about the way when we augment function from one system, and this one we're talking about the neck specifically, we kind of can think about it in like two different ideals. In one sense, it may change the signaling rate where it becomes extra noisy, like there's too much signal coming in, it's amplified. And that becomes overwhelming for the rest of the systems, and that's why it can bleed into other symptoms. And there are other times where it does the opposite, where it drops the firing rate so low that it causes like a lack of activity and we get a weighting where the other senses have to kick in and be more responsive. So this one becomes less responsive, which causes my eyes or my inner ear to have to become more sensitive, or they take on more weighting. And the reason that's important is because they look very different and the treatments are going to be very different. So for example, if I'm getting too much signal from my neck, I want to do things that start pulling that down and letting the other systems be able to compensate for them again. Whereas on the other side, if these babies just aren't kicking in and other systems are just way overcompensating, then I want to increase the inflow from these and start to down regulate my reliance on things like my vision or my inner ear. So you would treat them differently depending on how that's presenting in an individual person, which really comes down to those different integration points centrally. So I just wanted to make sure we're kind of aware of that, so we don't just assume like, oh, I got a whiplash, let's start cranking that neck out. Maybe, maybe not. We want to understand how that shows up in that person in the processing in the brain. Cool. Okay. So just real quick, what causes these things? So the three they kind of talked about in this paper would be like whiplash, car accidents, things we talked about earlier, poor posture, prolonged device use, working your tail off as a hairdresser for 37 years, things like that, ergonomic based things. And then things like hypermobility, um, connective, connective tissue sorts of diseases. EDS is the common one. I like to think about these as in these two buckets. So whiplash and car accidents, we're going to be creating hypomobility or rigidity within certain segments where it's not moving enough or it's not moving appropriately. Okay. Poor posture, prolonged device use, same thing. I'm decreasing the level of motion. I'm making it rigid. I'm making it move weird. Okay. Hypermobility means I'm not necessarily rigid per se. It means some of those joints may have more motility than they should, which is going to cause kind of that hypermobility side. But I also want to point out that if we see hypomobile joints or hypermobile joints, we want to then look at how that compares with the rest of the system. A lot of times, if we look at like whiplash car accidents, we'll see some segments that are really rigid. And then there's a breaking point where we then see a joint that is very extra mobile because it's making up for the rigidity in another group. Okay, so here's we have this combo where even though it's whiplash, and we've got this rigidity and movement, hypomobility, I may make up for that by creating hypermobility at certain segments as well. So then when we think about our EDS crowd, we want to look at the same thing. So maybe we're seeing hypermobility in some aspects, like I got it in certain joints, but then I also want to see, is that hypermobility across the whole system? Or are we seeing some segments that are hypermobile, but we're seeing the correlated response where we're creating rigidity to be able to support those in other places. So what I'm saying here is we shouldn't base it just on individual segments. We want to look at how they all work together and understand which is leading which. Do I want to create more mobility in the hypomobile segments? Or do I want to create more stability in the hypermobile segments? Depending on which one's kind of leading the charge or dragging the sled, you may change that. So we may see we will see times where people have been kind of prescribed as EDS cases. And we'll look at that upper cervical motion and be like, that's too much. But then we also look at the lower cervical segment and we'll say like it's so stinking rigid and come to realize that what we actually want to do is let's see if we can create some more control in that lower cervical spine and in those shoulder segments with the clavicle, the anterior musculature on the neck, control in the pelvis. And we actually see that by creating mobility in the lower portions of the spine, the upper cervical segments are actually able to stabilize without getting into kind of more invasive things where we're actually trying to change the structure in the neck. So that part's a little tougher. To be honest, there's a lot of nuance. We put a lot of thought into that. It's not just a quick solution for any of you. Really want to understand how they all work together. Kind of like when I was talking to Courtney, is kind of diving into that rather than just slapping a quick label on and then pushing you down the assembly line for being able to work through those. Okay, so I just wanted to kind of put that in your mind. A lot of people don't present it like that or think about it like that, but I think it's really important to look at how those systems play together to figure out how you best solve that problem. And then you may choose to do like a combination of those things or kind of get a little more nuanced in your approach. Back to Courtney again, popular gal, talking about imaging. So MRIs and CTs, they can show torn ligaments and they can show bony alignment, but they can miss sensor over or under activity, or the subtle functional issues. And that's kind of what I was trying to get at before in like a reasonably long-winded way before. And I really wholeheartedly believe that everything that we look at from a testing perspective, where we're looking at an image on a screen or an image that's printed out, needs to be correlated with physical exam findings, needs to be correlated with what you're seeing on the field. So it's like you're looking at a drone image. You need to also go and check that that's actually what's happening when it's playing out. So let me tell you a story. So years ago, my dad was hit in the back with a forklift. And when that happened, he started having pain. So immediately, you go in, you get an MRI, right? It's a work thing. So you get like it's all set up. And when you go get an MRI, he was in his he's in his 50s at the time. So he had some really mild osteophytes in his lumbar spine. Down, I want to, this has been quite a while now, but I want to say it was at the L5 level. Okay. And so they looked at that, no exam, and said, like, oh, well, what we'll do is a nerve block, and that should take care of the pain. But he called me and let me know that. And then I asked, like, well, but that doesn't seem like the pain you described. Describe your pain again for me. But what he described was a pain distribution that was above the level of that L5 disc. So an L5 injury wouldn't cause the type of pain that he was experiencing. So that immediately made me made me perk up and be like, I don't know, I don't think that's going to work. And for them, part of that workers' comp thing that some of you can relate to is you kind of have to do what the doctors say in that specialty in order to continue to get care and to continue to get taken care of. So he was reluctant. I was living out of state at the time, so I wasn't nearby. I was several states away. And he decided, try it out. Let's see it. He's a pretty adventurous guy. If you've ever met him, he's wonderful. But it didn't work. And then he's kind of had to languish there for a little while. So I ended up flying back home and spent a weekend with him and was able to see that what he was experiencing it wasn't from the discs at all. Where he had gotten hit in the skin around his back, he'd gotten hit in that the nerve that travels under the skin had gotten injured, and there was a neuroma on the nerve. So the nerve itself was the thing in the skin, not in the spine, was the thing that was causing the problem. But the only reason I could figure that out is because I put my hands on it and figured it out. And then from there, it was really easy to solve. And we were actually able to get him back up and get him working like over the weekend. And he was able to start stretching, lifting some weights, doing some mobility, and eventually get back to work, which was a super big deal for him. And like, it was amazing. But the point to the story is that we can't just look at pictures. We can't just look at blood work. We have to look at people too. There's so much more information from looking at people face to face, in person, in an exam that you just can't get in those other ways. So I don't know if that is like a sales pitch or a pulpit speech or soapbox with a bullhorn or what it is, but I truly think that especially if as you're going through the process of healing and it's not going great, get somebody to really get a hard look at you, not just at the screen that represents you virtually. So like, let's actually see what's going on with you. Okay, rant over, but worth talking about. Cool. Okay, let me just check in right here. Okay. I think I answered Amanda's question because she said, oops, too soon. But I think it's worth going over again. So the original cause of mechanoreceptor damage is trauma. A lot of times it is. It can be trauma that causes us to have swelling, inflammation, disconnection from the motion. So anybody who's ever like sprained an ankle or a knee or a shoulder, wrist, I don't know, a joint, it swells up and then it doesn't move real well, and you might develop a little limp, and then it takes some time to start to move it normal again. And if you don't spend time on it, sometimes you can keep that limp or keep that weird movement for a long time. Same idea in your neck. On the other side of that, you may experience it not from trauma necessarily, that is like a one-time trauma. You can also have it from repetitive use over time, which is a form of trauma. Um, that's what we were talking about earlier with postural changes. But then also we can get them from changes in the brain itself. So people that have different changes in brain activity or function may lose motor control in certain ways and get posturing that can then cause problems as well. So the simple ones would be things like dystonias, which are more common than you realize. Things like CP, things like we see in strokes or TIAs or even migraines, where we see changes in muscle posture that create changes in mechanoreception. So, really great question, actually, and I'm glad we got to cover it again. Good question. Thanks. All right, Marcy. Marcy said this information is new to me and very helpful. I need to work below the neck too. Very cool. Well, I hope it's helpful. Thank you very much for saying so. We'll keep rolling. Okay. So I think this part's interesting. So Courtney, I hope you're still on. So ways that we think about cervical joint problems from like putting hands on people. Eileen says my vision is slowly getting clearer with care. That's awesome. So one thing that doesn't get enough press is the fact that there are a lot of tests that have been around for like a super long time that are used for people that have some manual dexterity, to be able to look at these things on a functional level so that we can correlate it to what we see in imaging, which is cool. And actually, for this segment, my original plan was to bring over the lovely Dr. Mrs. Kaiser and use her as a model to be able to show you some of these, but I don't have her, so I can't use her as a model this time. But maybe what I can do is describe it. Shoot. I'll just have to use some words. I'm sorry. I think we should always demonstrate instead of describe, but I'm going to break my rule here and I'll try to do my best. So there's a thing called an anterior shear test. This is an easy one. Basically, when we palpate the neck, we can feel where that, like the C2 has its little projection up, and then there's on the way back there, you can feel the back of the C1 vertebrae where it rotates around the dens, kind of rotates around like this, if you can see my hands. So it pivots around the dens from the C2. And when it does that, so if we have the ligaments that hold that all together, I'll pull that up for you real quick. So let me, there. So when you look at these ligaments, so this right here is the top bone, the atlas. These are called condyles here. That's actually where your skull sits on top. So if you look at this side picture right here, your skull like rotates around on top of these condyles here. And then the second vertebrae down here underneath it, it's got this thing that sticks up. This is called a dens. It's like a little finger. And you can see all these ligaments kind of strap. These are like ratchet straps that strap that top bone around this baby so that you can pivot and rotate it like this. So a lot of the rotation that happens in your neck happens at this junction between those top two segments. So with craniocervical instability, the way you think about it with a DMX, when we're doing these lateral flexions and doing these things, if I do something that stretches or injures these ligaments, right? These are the ones that tend to cause some of that laxity where it moves too much and messes with people. But it turns out, if we go back a couple slides, we can do things to check with these just with motion. So we can first feel and see if there's too much glide, like that ligament just moves too much. Same as we can do with a knee, same as you can do with an ankle. We can also do ones where we hold it steady and create that pressure in the back, and you can oftentimes feel it kind of clunk underneath there. It's a clunk test. We know that we can also have people, you can have people laterally flex or laterally flex and rotate their head. And then you can kind of hold that segment steady, flex, or excuse me, laterally flex and rotate. And you'll notice that if you hold it steady, it should restrict the motion. But people that have that ligamentous laxity, it doesn't really. So you can hold that segment still, but they're still able to take it. When they do this motion, they're still able to go way further. And you can, if you ever felt it before, you would know it, because it's, if you feel ones that are stiff and they work real well, and then you feel one that's like, whoa, that shouldn't keep going like that. And you can feel that extra motion and it feels like a little wobble heady. Okay. And then you can also do things, simple one we do bedside really commonly is we'll just look at joint position error. Well, I'll say, we'll look at how well they track. Like if you look at my thumb, we'll look at how well you track, and I'll say, point your nose at it. And I'll have you follow it with your nose. And one of the things we should see is if it's all coordinated correctly and it's all speaking well, your eyes, if you look at my eyes, let me see here. So if we look at my eyes, they should stay right in the middle of the orbit, right? So if I'm looking right there, then when I'm following the target with my eyes, they shouldn't move over to the sides while I'm following. If they're moving to the sides, it means I can't coordinate where my head is relative to my eyes. So I should be able to point my nose at it and keep my eyes right in the middle, right? Without there being any error. And you'll see this is actually a super sensitive test for being able to look at these errors in that rotation. And then you can extrapolate that, moving them through different planes or in the vertical plane and taking them there. So these are really great tests to be able to just at the bedside, really fast understand if we're coordinating those systems really well. And we use that test all the time. And probably there's some of you out there right now that are trying to look at your thumb and then also look at your eyes in the mirror. And that's kind of tough to do. But, cameras and phones make that kind of thing a little easier if you're interested. Cool. So those are just simple ones. And then I'm going to just real quick touch on, I feel like it's unfair to not tell you how to think about solving it. So when we see that integrity breakdown, where the ability for your neck to communicate with your ears and your eyes and process in the brain correctly, we think we break that down. So we take it apart and we say, how well do the eyes work on their own? How well does the vestibular system work on its own? How does the neck work on its own? Okay. Then we start to put them together and we say, well, what if we take just the neck and the inner ear and look at that integration? How's that looking? What if we take just the neck and the eyes, or the eyes and the ear, right? And we just look at them each separately, and then we start to couple them together, and then we start to run all of them at the same time. And that helps us gather some precision about where those errors are occurring. And then we simply take them apart and work on drills and exercises that help us do it perfectly again. Because if you can do it perfectly, you're training your brain. It's like you're relearning how to do it. And if you can do that, you can build the plasticity, regain that functionality, and then make more and more complexity. So here we gave a couple examples of proprioceptive or balance exercises. Those may apply to your neck, but they can apply to your inner ear and your eyes as well. Obviously, eye movement coordination drills, whether that's eye movement on their own, or eye movement with head movement, or eye movement with posture, or eye movement with dual tasking. We can layer in all of those different things. Manual therapy can be very, very helpful for just guiding those joints for how to move again. It's actually one of the most useful things. It's one of the most gentle things. We do it in a way where you're almost like trying to give the least amount of pressure possible, because you're trying to give just enough for your brain to be able to figure out how to control it again. Last thing on there is in the acute phases. So if we want to reduce the inflammation, you can use things like PRP, ACS injections, anti-inflammatories. But again, these are things that help us kind of in that co-management, where you may say, like, I just want to help reduce some of that symptom burden while I'm retraining because it's interfering with that training. Or it may be like I'm suffering in a way that is just unbearable. And then you can use those things in the short term while then getting to the retraining. But inevitably, you're going to have to retrain it, because you can't induce neuroplasticity without a stimulus. And that's super important. So they've done this test. So they say, we know that you need oxygen, glucose and stimulation in order to be able to keep a neuron alive. Okay. But if you just give a cell glucose, it doesn't do anything. You can't like sugar your way into like more healthy or stronger cells, neurons. You can't oxygenate them to make them stronger. It's good for them. They're both good adjuncts. You need both of those things to make them worse, to make them work. But the one thing that is non-negotiable is you have to use it. Because if you don't use it, the machine doesn't run. So you can fill it with gas, you can get it ready to go, but if you never turn the key, it doesn't really matter. You're not using it. So stimulation is the one portion of that system that you can't do without. So by doing things that reduce inflammation, you're kind of actually like taking away your body's tool for healing it. But you have to then come over top of it and do the things that train it so that you can generate a neurological signal and then you can start to control it again. Without that, you can't improve the control mechanism through chemistry. It just doesn't work that way. It would be way easier if it did, to be honest with you. So we have to think about things that actually stimulate the tissue. You have to stimulate the appropriate tissue for the injury, and you have to do it at a dose that is appropriate for the tissue's health. So some people can take more, some people can take less. And that's kind of like my nutshell on how to think about that. Cool. So people that would benefit from that would be basically people with lingering problems, things like dizziness after concussion, dizziness after an MVA or whiplash. Our POTS team responds very well. This is a good conceptual way to think about this for them, especially if you're having orthostatic problems, symptoms are worse when you stand up. ME/CFS blurs right into this system as well. And then when you're thinking about unexplained balance, visual fatigue, dizziness, all of these things, you want to step back. If you're beating your head against the wall and you're not getting there, this may be a model that may be useful for you to think about in those cases. So I hope that's helpful. I think that's basically the nuts and bolts of what I put together for everybody. I'm going to pull this down. I'm going to pull me up, and then I'll take some of these questions here. And once we're done with these questions, we'll probably call it a night and let everybody get some shut eye, some beauty sleep, and away we go. Okay, so we left off with this one where Eileen let us know that her vision's getting better or getting clearer with care, which is awesome. Keep going. Oh, I got some wild hair. This is the first time I've seen it. It's a little windy out there. I got caught in a little rainstorm. We're working it through. Okay. Does the neck and brain heal at different rates? Is one quicker than the other? Great question, Megan B. So tissues heal at different rates, and we know this. So the easiest two to think about would be muscles and neurons. So if I am a weightlifter, I always go back to weightlifting. I apologize. You can see like in the background here that is a thing that I enjoy. So if I think about weightlifting, I can only come over here and just really have fun flexing my chest, working on that like once a week, maybe once every 10 days, right? That's what you need in order for a myocyte or a muscle cell to be able to recover. That's its half-life for recovery. That's the time it takes to heal. But if I look at something like a neuron, neurons are designed to change really fast because we have to learn. So if we think about a neuron, neurons can be as fast as milliseconds, right? But then we may look at something like a hormone, where hormones are designed to change over slower periods of time. So you may look at those things changing in terms of weeks. And then when you think of things like a ligament or even a tendon, those are going to be even slower because their whole job is stability, right? Their job is to undergo tension and not break. So they're designed to work slow, to remodel slowly. You think about like a bone healing works at a different speed than ligaments healing. When I was a kid, I sprained my ankle playing football. I had, I got made a tackle at the line. Kid that was bigger than me fell on my leg, sprained my ankle. And I remember when I went and got it checked out, they were like, oh, yeah, when we see these, actually, a lot of times we kind of hope they break because if the bone breaks, it actually heals faster than the ligaments do. And anybody who's had that high ankle sprain, probably, I'm probably bringing back memories. Sorry for the Sorry for the bad dream tonight. But so you can extrapolate that. If we're looking at the same thing in your neck, we would have the expectation that it's going to heal a little bit slower. And if that's the expectation, sometimes that gives you a little bit of freedom to be patient with it, but no one's ever patient in this game. So yeah, brain and neck are going to heal at different rates if we're thinking about it in terms of soft tissue versus neurological tissue. Neurological tissue is designed to heal quick, 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 because it has to, because it's got to learn. That's like the whole purpose of that tissue. Good question. Eileen just giving us a little shout out, said, I noticed that the tinnitus is better with the upper cervical chiropractic. So yeah, so changing that afferentation or even the positioning of your neck may have pretty solid influences on that for those of you that have tried that. Worth checking out with tinnitus. Isaac, welcome, welcome. During sleep, I have a sudden feeling over. I mean, this I can't read it. During sleep, I have a sudden feeling over the front of my neck, distinctive sound, or sometimes string of muscles twisting like feeling and sound in my mind wakes me from sleep. Can help understand why. Isaac, I feel like that's a good question, but I also feel like I don't quite perfectly understand it. Let me see if I can try again. So you get a sudden feeling over the front of your neck. There's a sound or something that's like muscle twisting or feeling the sound in your mind that wakes you from your sleep. Can you understand why? Man, I'm gonna have a tough time answering that because I'm not sure. I don't know if it's from the position or if you're having a spasm or if it's something that's happening in your dream, but I would like to help you understand. So maybe give me a couple more words on that and help me understand it a little bit better, and I can be more useful. Eileen, I have lax ligaments, unfortunately, so we're strengthening deep flexors in the neck. I love that strategy. May need more than even deep neck flexors. Maybe needs to look at a little more coordination as well. But I love it. That's a wonderful start. Keep doing it. Big Worm. Big Worm. Do you believe in those vagus nerve stimulators? Do I believe in them? I believe that there is a way to stimulate the vagus nerve. And I believe in people when people have, okay, I'm going to break it down for you. Two ways. Number one, vagus nerve stimulator useful if, number one, you've got an injury in the vagus nerve that has actually changed it. We saw a bunch of these with with a thing we're not supposed to talk about, and then the solution to that thing. We were seeing peripheral nerve diseases. Guillain-Barré was a big one, and they can just go super random in terms of what they affect. And we did see people where they Dr. Ginny is chirping me in the private chat. Yeah, so we did see in those cases where we would see direct like chewing or destruction in the vagus nerve. We use vagus nerve stimulators quite a bit in those cases to try to increase that signal rate again. Okay. So if there's damage within the vagus nerve that you can find, that's a good place to use one. And then number two would be if you're going to use it as a modulation technique, which means I'm going to use it as basically like a metronome to my brain. So I'm going to say my vagus nerve is actually working well. I'm going to stimulate it because I'm trying to target something in my brain to improve the functionality there and using it as a neural modulator. Okay. So those are the two ways that I would use them. People will be a little more adventurous in the way they use or prescribe them. I would say that we tend to see, so like in our office, we're not usually seeing people, like we're not the first place people end up for whatever reason. Usually you try to exhaust the things that are a little closer to you. That's reasonable. So we see them down the road. And I would say that most of the people that are prescribed vagus nerve stimulators that we see, it's done for not a particularly logical reason. But that also might be the people that prescribe them for good, solid reasons don't end up having to come and see us. So there's probably an exposure bias there. So do I believe in them? I believe there are applications where they're useful. I don't believe that they're going to cure everything that you have just by sticking one on your neck. And we have seen cases where they actually are not very useful and they can make things worse. So it's a tool. Use it appropriately, understand why you're using it. That would be my would be my thought. Response from Big Herb. No, I'm just regular pod student. Big Herb, I want to meet you in person. I'm just a regular pod student. I don't know if there's much value in using those stimulators, things in my case. I don't know either. But if you're having a problem with cardiovagal outputs, then that could be a reason to use one. Those tend to trend more toward things like IST, um, inappropriate sinus tachycardia, where you'll see the heart rate lives higher. It doesn't settle down as well as it should. And then fluctuations, like when you're doing stuff, it cranks high. Those would be reasons to consider doing that. And doing a deep breathing test can be a way to help define that. Cool. Good question. Thank you so much. All right. Amanda, how do you got this camera in a bad spot. How do you restart this when it was so difficult that an hour of this balanced proprioception PT OT made me sleep, dizzy, nauseous for the day? I've tried baby steps, but it seems no matter. So this is a good question. This is one we get almost every person that calls Claire is like, am I going to be able to handle this? We take people that can't do anything and we'll see them all day long. But the reason is because we're looking for things that are cues for how much work somebody can do. So you're not just kind of flinging them into an algorithm. We're actually watching it step by step and looking for, okay, we're going to take you up to this point and then we stop and rest. And we'll take you up until this point and then we stop and rest. And we measure like when you're recovering and we push people slowly through that way. So an hour of all of this stuff at once is probably a lot, but depends on how hard you're hitting it. And it depends on also kind of a departure, but it depends on also if all of the exercises you're doing are targeted toward the thing we need to target them to. So if we already have a low tolerance or a low, let's call it a battery. Let's say your battery doesn't charge all the way anyway. And if I'm doing things that are extraneous to the problem, I'm doing things that are generally good, but maybe not specifically good for me, I'm going to drain that battery out. I'm going to potentially overwhelm some of those sensory systems, which can give me symptoms. It's going to be harder for me to recover. Whereas I can spend way less time targeting just the one little tiny thing we're trying to scratch at. And then I'm not using as much battery, but then I'm also only focusing on the thing that's wrong. So I'm not going to overwhelm the sensory system. I'm not going to induce symptoms the same way. So I think this is really important, but it's part of the nuance of not putting people in an algorithm or like looking it up on ChatGPT before they come in. It's like having a nuanced understanding of what's the right dose, how are we going to measure for when we've hit the dose, and how do we appropriate rest, and then how do we know how to continue that over time so that you're building over time. Cool. So think about it that way, please. Please and thank you to Amanda Sutherland. Extraordinaire. Courtney's back. Courtney says, what does it mean if nuclear adjustments make things worse? Well, I don't know that it means one thing, first of all, but one thing that you could take away from that, it may mean that type of manipulation. So a thing to consider for a lot of people is that sometimes that change in mechanoreception in your neck is the compensation. So if I have problems with stability in my ear or processing from my ear or my eyes or in that vestibular system, if I've got problems there, the reflex to that can be a cervical colic reflex, where I'm actually going to create tension or rigidity in the neck as a way to create stability so I'm not getting as dizzy or I'm not feeling spacey or disconnected. And then if I take that compensation away by reducing muscle spindle activation or making that joint more mobile, it can make my symptoms feel worse because that was the one thing that was holding me together, preventing me from kind of feeling all over the place. So a lot of times when we steal a compensation like that, people will feel worse. What we want to do instead is solve the problem at hand first, and then come in behind that and then reduce the muscles, take the compensation away. It's like scaffolding. It's like you don't want to take the scaffolding down until you're done with the job. So if your neck is acting as scaffolding to keep everything rigid, we want to make sure the integration is good and then peel that last piece out with the neck. Good question. As always, we pickleball soon. Catching up with Corey. Yeah, we were talking about the thing you cannot talk about. All right, Nomad. Let me pull you. Give me 1 second. I'm going to move this over here. I'm going to move a cord real quick. Give me just a second. Okay. That's better. Why do MRIs feel like such a miss when it comes to chronic neck or brain issues and neuroinflammation? Ooh, spicy question. I like it. So, MRIs are a picture in time, and they're a picture of structure. The way I think about it in my head, I don't know if it'll fit in yours, but you can try it on. As I think about it as like my car is on the side of the road and it will not run. Okay. If I take a picture of the outside of the car and send it to the mechanic, they will be like, looks great, right? Now, it doesn't tell me what's wrong. It doesn't tell me that, there's something wrong with the alternator, right? You can't see that. You have to run the car, you have to run the computer, you have to actually make it work to be able to then understand that. Whereas if we have somebody that has a severe structural change in the brain, right? They actually have a stroke or they have a tumor or they have something where we're seeing infiltration of inflammation to where it's caused the damage. You can't see the inflammation itself, but we can see the damage it causes. It's kind of more like your car's in the side of the road smashed because you ran into a semi truck and you take a picture and now it's easy to see where that damage is because you can see it on the body. And that's kind of like what an MRI does is it helps us see those things. Ton of value in an MRI, especially for acute patients. But when it comes to things that are more functional, how does it work? And they're not problems that come from those big acute damaging structural problems. Taking the picture doesn't seem to help as much. I think there will be a time where we can visualize that better. I think machine learning is going to take that a long way. But right now, MRI is kind of like taking a Polaroid, right? You can get a nice picture of it. But what we really need is to be able to like envision the electricity that's moving around through the system. So we can't see it yet, but we can watch it work and we can watch the outputs. And for now, that's the tool that we have. That's the best tool. I think that those tools will keep growing in a pretty profound way. But right now, we got to help the people that are hurting right now, and those are the things that are available is to look at how they work, how they function. Cool, good question. I think I'm gonna like you. Okay. All right, Bigger. Thank you so much for clarifying. Want to come see you? Need to see if my finances will permit a week of your time. I should book a consult. I know the financial part's tough. I hate that. I hate that part. It's just the crummy part about not being able to fit into kind of the conventional system. We just don't fit. So it's harder to operate that way. But anything we can do to help, man, I'd love to do it. Amanda, thank you. Isaac, our good friend, I do have neck spasm, but I have feelings that when I let myself into deep sleep, like when I'm not remunerating my thoughts, maybe ruminating on thoughts, that's when you have it. I'm very interested in that. I would like to see what that looks like and maybe understand a little bit more about what's going on. And I think I could give you a better answer, but as it stands right now, I don't know that I'm sure how to help Isaac. Yeah, let me know. We need more info. I need something to observe. Okay. I wish I had a better answer for you, but I'm not. I don't want to give you. I don't want to steer you wrong. Okay, Eileen. Yes. Is this high fives? I'm going to say it. This feels like high fives to me. It aggravates me when people say prolotherapy takes care of all the symptoms, but you got to do the work. I agree with that. I don't throw shade at prolotherapy. I think it's a great tool. I think any tool used right is awesome, right? If you got, if the only tool you have is a set of tweezers, you might not be great in the auto mechanic, but you might be awesome for splinters. You know what I mean? So any tool can be great, but we should use them with kind of just a wide understanding of why we're applying those tools. And I'm all in for that. Cool. Nomad, thank you for that on the MRI. Yeah, I think it's a great tool. We use them all the time, but we just wish we had better stuff for other things. Oh, Ilsa, I'm not sure. I'm gonna pull these up real quick. I'm not sure. You might be throwing some stuff at me that I don't even know about. I hope it's nice. I hope you're being sweet and these are nice things and you're not making fun of me. So let me know. Eileen, I miss weight training so much. Slowly getting there. Deadlifts are my favorite. I did deadlifts today. Loved it. Wish I was stronger, to be honest with you. It must be getting old. Doing these now without the weights. Love it. Great job. Eileen, I love hearing about your progress. It makes me so happy. Don't stop doing that. All right. Oh, I see where you're going with this. Dynamic upright MRIs as a future technology invention. I actually, like a crazy person, looked into trying to do this. What I was running into, I wanted to see some things with the brain as well. And I was trying to figure this out. But you need like a pretty high Tesla magnet. We want to do some things looking at dopamine projections in Parkinson's cases where they actually, what's kind of wild is so I won't bore you with it, but in the substantia nigra where you have the melanocytes or the neuromelanin, it gets replaced by iron, and you can see it on this certain type of MRI where they do this like cross modeling. It's wild. I don't really understand it, but it's super cool. And we were looking at that, and we were looking at doing these dynamic motion MRIs where we want to see people upright. I think one of the biggest problems with doing MRIs is they're all laying down, so they're all in perfect, posture. But then when we sit people up, that's not how they look anymore. So that's my personal gripe is like a lot of the stuff we look at in the postural system needs to be in posture, and everybody knows that. But the problem is to do it, you got to get these two giant magnets and stand them up like this and stick people between the two of them. So the magnets are as big as a room. And so right now we're kind of that is one of the limiting factors is literally just like the size of the magnet for certain things. Certain things that take lower resolution, you can see them. Um, but yeah, please build this for us. I will be your first customer. I'm very happy to have it. By the way, Dr. Ginia says that it is 2:30 a.m. where you're from. So big shout out to you. If you're up this late, let's do something amazing. Let's make a dynamic upright MRI. Let's get to work. Okay. So no more sleeping for you. We know what your purpose is. So thanks for being here. I hope you get some sleep though, too. All right. Oh, big erm. So this is like hooray. All right. Or is it like one of the like a raise the roof? That feels old to me. Um, I like double high fives, but maybe it is just hooray. Said in a fun voice. Bigger arm, I bet you have a good hooray voice. Corey, CCI treatment is going to boom with ML. Hopefully fusions can be a thing of the past. I see this creating new industries. Yeah, machine learning. I think it's going to bring a ton of change. I'm very interested in it. I think humans will always have a place because as long as we're problem solving, we'll be working it through. But just putting better tools in people's hands, I hope that makes a big difference. I'm with you. I hope that comes incredibly fast. There's your job. I'm handing out jobs today, team. So here we got Elsa. She's going dynamic MRI. Corey's using machine learning to just make pristine necks. Who's next? Lyme India's in the zone. Aha, I get it now. Lyme in the zone. Let's see. My neck hurts. My neck hurts when I have seizures due to the positions I get in. I do understand that. I've seen that, especially with we get a lot of the twisting and torsions and they're sustained. I actually had a good friend of mine was having some these myoclonic jerks. And so myoclonic jerks a little bit different. So it's not like that sustained experience that you're having a seizure necessarily if it's sustained. But if we start to get into the jerking component, he actually fractured one of his transverse spinuses in his low back. So basically, he like broke off a piece of a bone in his low back because that spasm is so bad. So I know that these are brutal. Don't do that. I'm not putting that in your world. but that can definitely be a thing. Let's try to see. I don't know where you're at, but trying to get somebody that can help you to be able, one, maybe even reduce some of the intensity of the seizures, but also be able to help you with recovery with your neck afterwards. Might make a big difference in your life. So thanks for sharing that. I'm sorry to hear it. But maybe there's upside to be able to solve that. All right. Isaac, I do agree, Doc. I really appreciate making yourself available to the community to help understand about medicine and helping get a solid knowledge. That's really nice of you. I really appreciate that. Can I know where to reach out to you? Is the rest of it. So to reach out to us, to contact us at the clinic, um, we can put it in the chat. We'll have Dr. Jania throw that in the chat. Also, shout out to Dr. Jania for being here, helping us out. Wonderful, wonderful teammate. Brilliant, brilliant, brilliant. But she'll throw it in there. The email that we use is info@drkaiser.com. And then we also have a line where through the phone, obviously we can take phone calls, but then we also can take text messages as well. And it connects you with members from our team. And then that's kind of usually begins the process of how people reach out to us, ask questions. If it's a question that's more of like a technical question, like you're asking, email might be the best way to do that. Cool. All right. Joanna says, Lyme, she's talking about Lyme in the zone. My neck starts hurting and sometimes triggers the seizure. I've seen lots of that too, where the positioning of the neck can actually cause changes in vascularity or neurogenic signals that then lead to the seizure. So we can induce them in neck positions. But what's really cool, like the case I'm thinking about in my mind, is by like creating that motion again. Sometimes if those are kind of the catalyst points, by walking that back and being able to reduce that constriction, or especially if it's a blood flow related problem or a neurogenic problem, we can solve that. A lot of times, like, the case I'm thinking about drastically reduces the seizures to very low. Now, I don't want to say that for everyone, because seizure burden, time under that, things like Dravet's, different syndromes can make that look way different. Definitely need a fine tooth comb when you're looking at things that induce seizures, but also maybe a way to start to, like, maybe you can find just a little wiggle room in there to be able to make it better. So I'm rooting for both of you guys. Let us know if we can help. Jody, so thankful for your knowledge. You bring me much hope for my daughter, who will have her first assessment with you at the end of the month. All right, so we got like a team of people that are getting prepped and ready. So I love it. Thanks for spending time with us, and I really, 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 really hope that we can help. Just a quick shout out to Nadine. If you got questions, let us know. You can reach out through the email. You can also reach out through the text message. If you pop in our contact form on the website too, that's also a way that you can grab us. Cool. South Africa in the house. Love that. I'm like still old enough to remember when the internet wasn't a thing. This still blows my mind that we are connected to this many people right now. And it's just like goosebumps me. I love it. Thanks for being here. Love it. I love it. Ritvik, hey, what's happening? What does being concussed feel like? I ask because I think I would describe some of my POTS symptoms, but I'm not sure how it is defined by a doctor. Thanks so much for helping. Ooh, good question. So, what does it feel like? I tend to think about, I'm not so much of a feels diagnostician. I'm more of like what does it measure out like? Like, how do your eyes move? How does your autonomic system work? How does your vestibular system work? Your motor system, cranial nerves. How do you walk? That's kind of more how I look at it. But if we think about what it feels like, those symptoms we describe can be pretty broad, but they can also define a lot of people. So simple things like headaches, brain fog, dizziness, fatigue, eye problems like oculomotor problems, autonomic problems, things like POTS, balance problems with coordination, light sensitivity, sound sensitivity, motion sensitivity, changes in gravity or otolithic sensitivity. Um, all of those things can be wound into that concussion diagnosis, which is actually so. Some of you probably heard me say this before, but the way I came into the autonomic world was through the world of concussion. Um, we were seeing concussion cases, and there was a cohort of concussion cases that had autonomic changes far in a way more pronounced than other people did. So they were like in that category. And that is where we spend a lot of time working on like how do we think about these? How do we solve these problems? How do we understand them better? And that kind of that problem solving kind of led to different testing strategies, which led to different understanding, which led to different treatment processes. So there's a lot of overlap there with concussion and POTS specifically, or different types of autonomic problems. But it has that general feel. I used to describe it. I did a lecture a long time ago for, I can't remember who it was for now. I think it was somewhere in, it was actually for a group up in Calgary area. And I was speaking to attorneys. So a lot of attorneys probably, you know, they may not have experienced concussions. Although in Canada, we got hockey, we got horses, we got ice. Probably maybe a lot of them have. But I described it as like a hangover that just doesn't end. Um, and so for people that have never felt it before, that might be a way. That might be a way to think about it. Is some of those similar feelings that people would have with a hangover that just doesn't go away. If you're feeling POTS with a concussion, let's try to look at some things objectively and see how things are working together. And if we understand that, that kind of paints the picture for what to do afterwards. So, how are your eyes working? Oculomotor testing. How is your inner ear working? How are all your cranial nerves working? Is your blood flow, are those reflexes normal? Do you move normally, right? When you try to, move, do simple things with your hands and with your feet, right? Do you feel normally? If somebody draws on your foot, do you feel it? If somebody pricks you with a pen, do you feel it? Can you feel vibration? Is your hearing normal? Do you walk normal? Um, is your balance right? Are you able to move your head and your eyes without it breaking down? So like all of those things will kind of point you in the direction of what to then think about for fixing it, if that helps. Cool. Oh, what a compliment. Very late for me, to say the least. Worth it though. Thanks so much. I appreciate you staying up late. I'm sorry that we make you stay up late. Um, but thanks for being here. Marcy. I use sometimes to give praise. Awesome. I'm gonna start using the old double high fives a lot more. And Megan agrees with me. So what I'm gonna start doing is when I think I'm funny, I'm just gonna start pulling up Megan's laughy face emoji and pretend that she is saying this to whatever I say. So if I say something that I feel is real good, I'm just gonna throw up Megan Bradford's laughing, and then I'll know that I've got a fan. And then I'm gonna do the same with you, Amanda. Good delegation skills. I'm gonna do this as well. So anytime that somebody's got a good idea, I'm gonna pop this up and say, Amanda says, build it, and then we will build it. So Ilsa's got a sweet MRI coming. Corey's just gonna build us like an AI that'll do whatever we want. We're gonna crush it. We're gonna have an awesome team. Okay. Oh man, I'm getting behind. Okay, so I'm gonna take about 10 more minutes, go through these, and then I've got to get to bed because I gotta go to the clinic in the morning. Irene, is there a possibility that someone already has C1, 2, and 3 fusion, could have pins removed and reworked with new treatments going? I don't know. Right now, I don't know that I'd say that that's a sweet idea. I think that might come with challenges. But if Corey gets to work, then that might be a thing in the future. I don't know. I hope things like that come. And with the way tech moves, I hope that that's like a thing that we're definitely talking about in the near future. That'd be wonderful. Nomad, I've heard incredible things about craniosacral. Is it relevant to talk about this topic? It can be. Craniosacral work is mostly going to be trying to manipulate components of obviously the sacral system, but also cranial bones in your head to be able to improve some of that motion. There's like a pulsation that happens within the joints of your skull that are really hard to kind of get a hold of. that can influence the way that cerebrospinal fluid travels through the system. And cerebrospinal fluid has this great benefit of being able to kind of clean house in your brain, and blocking of that system causes its own problems. So craniosacral therapy, where we're kind of allowing those things to move better, can have really positive outcomes for people. Good question. I've injured myself a lot working with a physio to build strength. Let's tone it down. So if you're injuring yourself a lot, then it's too much. So we got to bring the dose down, do things that are within your capacity, stop them once you start breaking form. So I like doing this. So I picture in my mind like somebody doing curls. And if I'm doing curls and I want to do them well, I have this beautiful posture when I do it. But then if I get to the end of it and I'm like, oh, my arms won't do it anymore, I might do this thing where I like, oh, lean in and like let my back and gravity and arms like take over. So it compensates. So what we want to do is, even if it's like with your eye movement, or even if it's the way we're pushing like a Valsalva, we want to take it to the point where you can still just barely do a perfect one and it just starts to break and then we stop. And I think that can apply as well when you're thinking about PT, is trying to do it perfectly right up until the edge, and then that's enough. So you're getting enough to create the growth, but not so much that you create damage. Good questions. Ilsa, shout out to Dr. Ginia, super nice, absolutely. Lime, thanks again for saying that. All right, Megan. Megan, is neck a big factor in migraines, specifically ones with auras? I think you did a good job here. Migraine, pretty good. Good spelling. Good spelling. Oh man, your smileys got too far away. So we'll use those. So can it be a big factor in migraine? It can. But it depends on, number one, we have to know that it is a migraine for sure. Sometimes we feel a unilateral headache and it may be cervicogenic. Ones with auras, that's how we classify things as migraine. And then with that aura, sometimes problems with neck proprioception with musculogenetic components, but also if we're constricting blood flow that's going into the occipital cortex or into the retina, where it can then cause that vasospasm to happen. Those are pretty common. So a lot of times in migraine cases, when we look at the transcranial Doppler, we will see changes in, if I sit up, my color's a lot better. We'll see changes in the pulsatility indices, where we see more resistance in people that have a migraine, especially on the side that they have a migraine. So we'll actually see changes in the pulsatility indices relative to that. So it's almost like that vasculature sensitizes, and as it responds to pressure changes in the brain for whatever reason, it kind of resists that and almost has like a spasm in a way. When I first started coming up with Dr. Carrick, one of the ways we always looked at this was looking in the eye. When you look through the pupil to the back of the eye, you can see the blood vessels in the back, and you can see the ratios of how big a vein is versus how big the artery is that travels next to it. And they should be pretty close to the same size. But in people that are migraineurs, we tend to see that toward those events, those arteries will get super skinny, and you can see that in the vessels in the eyes. And the same thing can be projected when we look at the Doppler, where you can see that vessels giving resistance and causing a greater pulsatility index. So it can occur with changes in neck because of changes in the vasculature, but also changes in just like the proprioceptive awareness of where your head is. It's not the only reason you have migraine. Obviously, people have different triggers, hormone-related things. You know, the bucket theory is a common theory about all of these things kind of add up and you spill over, and away you go. I'm in the zone. My concussions are now called FND. I believe I have autonomic problems. I see very, very, very frequently that FND, functional neurological disorder, and autonomic problems tend to line up. And I think that is a huge tell for understanding some of the origin for some people, not everyone, of FND. FND, functional neurologic disorder, is kind of like we've been talking about, where you're looking at function changes in the brain that you can't visualize, that are hard to be able to make sense of in that normal nomenclature, but we can see that there's a problem that's happening underneath it. But the kind of like conventional understanding doesn't support or understand how to use convention to be able to help those. But I would definitely look at that. Those two things tend to run together from the cases that we see. Joanna, when my neck starts hurting, it makes the sound move. I was told the blood vessel behind the ear. Hold on a second. I can't read this. I got to move over. When my neck starts hurting, it makes the sound move. I was told it's the blood vessel behind the eardrum pulsing or a silent migraine. Well, it can be. The blood vessel behind there shouldn't have that much of a pulsatility. It should just be relatively smooth. But right, when you're having an increase in the constriction or the tension in the vessels, sometimes that happens. The other time it happens is if we're having a hard time draining the blood out and it's just kind of filling into the venous system. So sometimes it can be arterial, sometimes it can be venous. Great call. Ooh-wee. Mary's cheering us all on. Triple double high fives. And then Corey is gonna, don't sleep on Corey. He's probably gonna build this. He's gonna be a trillionaire. So everybody be real nice to him. Maybe he'll help you out. Irene says, thank you. Megan's here for my funnies. Let's see here. I'm in the zone. Thank you for saying that. I appreciate it. And we got a mind blown emoji from Joanna. Very cool. All right, team. I love you all. Thank you for being here. We put in almost 2 hours. Solid work. Appreciate you guys hanging with me through the whole thing. Let me know what you're thinking of this time slot. I'm gonna give one more. Also, slide them in at the bell. Get them in early. Don't miss your chance. Christian says, I have a herniated disc with nerve pain and PT isn't working. What should I do? Okay, so if it's herniated, you got to know I'm not going to give you advice, but I'm going to give you things to think about. Okay. So things to think about, is the herniated disc the thing that's actually the pain generator? That's step one. Because if you're chasing that disc down and it's not the thing that's generating the pain, you're never going to win the game because you're playing the wrong game. So that's number one. And then number two would be, if it is from the disc, then we have to understand, how do you take the pressure off of that? Is that disc amenable or is it mobile? You doing things like long axis traction, or using, decompression is a wonderful tool that doesn't get enough press. I don't even do it in my office, and I refer tons of people for it. So something to consider. Hopefully that's what you're doing. But non-surgical decompression can be a wonderful tool. If you're having a disc herniation where you get extrusion of the disc, where it's kind of outside of the normal ligamentous structure, that can be problematic. That's where things become more surgical. But I think you got to solve problems in that plane, where first, make sure that the pain's actually coming from that. Sometimes it's not. And then second is, are we doing things that create mobility in that disc in a way that's going to be effective? Again, for my money, I like non-surgical decompression. That's my favorite. I don't know if that's what you're doing or if that's on the table, but those are the things that I think about. Amanda, middle ear myoclonus that occurs during a migraine, my eardrum flutters. Maybe that's what you meant. That could be true. That's pretty wild. Yeah, so I'm curious if your hearing fluctuates with that too. If you get like the spasm, like if it's pulsatile, sometimes that facial artery as it comes around can cause that. And you can even see it like in the face as well as hearing it in the ear. Yeah, that's really interesting. And then sometimes the Valsalva, blowing into your nose and seeing if you can expand that, or even, like quick bounce up and down, like a little jostle to see if that breaks that spasm is very interesting too. Not saying that you should do that, but it's the things that we've seen in the past. When I was with Dr. Carrick, I got to see he opened my mind to a whole different way to think about those things. So I'm forever grateful to him. Okay, guys, big worm, big perm. Good to see you. Glad you're here. Christian, thank you. Amanda, yeah, unilateral pulsing. Exactly. Yeah, interesting stuff. Thank you guys for being here. I'm going to go to bed so I can take care of the folks we got in tomorrow. Thank you. We'll be back at 8 o'clock tomorrow. I'm not going to be back at 8 tomorrow, but I'll be back at 8 next Thursday. We'll party again. I'll try to bring a good concept that brings you guys lots of questions, and we will get after it. So thank you all so much. Be safe. let's work toward getting healthy together. I'll talk to you soon.